Hey everyone, and welcome. If you're gearing up for your clinical exams, you know just how nerve-wracking they can be. Well, today, we're going to break down the OSCE and give you a clear, repeatable system that you can rely on. Let's get right into it.
The classic OSCE scenario, right? The pressure is on, that clock is ticking, and the examiner is watching your every move. It can feel completely overwhelming. But here's the secret. The key isn't just knowing all the information, it's having a structure to hang it on. And that's exactly what we're going to build today. A solid framework you can fall back on, even when you're under pressure.
So here's our game plan. We'll start with the foundational framework that will help you ace any clinical exam. Then we'll apply it step by step to the respiratory, cardiovascular, and abdominal systems. And to wrap it all up, we'll go through a pre-exam checklist that you absolutely cannot afford to miss.
Okay, let's kick things off with Section 1, the foundation. Look, it doesn't matter what system you're asked to examine, it all comes down to these 4 pillars. Think of this as your master key for any clinical encounter you're going to face.
And this is it: inspection, palpation, percussion, and auscultation. IPA. Seriously, this simple little sequence is your secret weapon. It stops you from forgetting steps and it makes sure your examination is thorough, logical, and confident every single time. Look, touch, tap, listen. That's it.
All right, let's put this framework into practice. We're going to jump into our first system and apply IPA directly to the respiratory exam.
See, the same 4 steps in the exact same order. This is the beauty of the system. You don't have to reinvent the wheel for every single exam. You just follow the proven method. So for inspection, the most important thing is to use your eyes before you use your hands. Are there any deformations, like a barrel chest, that might point to COPD? Is the patient using extra muscles to breathe, which could signal respiratory distress? Is the trachea right in the middle? These visual clues give you so much information before you even touch the patient.
Okay, next up is palpation, or touch. First, you'll confirm the tracheal position with your fingers. Then you're going to place your hands on the chest to check for symmetrical expansion when they breathe in. You're looking for more than 5 centimeters of movement. And finally, you'll check for something called vocal fremitus, which is a really neat diagnostic tool we'll look at right now.
So, this vocal fremitus, what are we actually feeling for? It's really just the vibration you feel on the chest wall when the patient speaks. But what makes it so useful is how it changes depending on what's going on inside. You know, increased vibration can suggest something solid is in there, like consolidation from pneumonia, while less vibration might mean air or fluid is blocking the sound. It's a simple test, but it's powerful.
And finally, we tap and listen. With percussion, you're listening for a nice, resonant, hollow sound over healthy lung. If it sounds dull, that could mean fluid. Then, with auscultation, you're listening for normal, clear breath sounds, and you're actively hunting for any abnormal sounds like crackles or wheezes. And the golden rule here? For both percussion and auscultation, you have to compare one side to the other.
Awesome. Now that we've got the respiratory system down, let's take that same exact framework and apply it to the heart and the cardiovascular system.
And what do you know? It's our old friend, APA. The process doesn't change, just the specific things we're looking, feeling, and listening for. It's this repetition that builds that muscle memory and that all-important confidence. For the cardiovascular system, inspection starts with just looking for any visible pulsations on the chest. Then palpation is all about confirming the location of the apex beat. You're also feeling for 2 really key signs: thrills, which are these buzzing vibrations that literally feel like a purring cat and suggest turbulent blood flow, and heaves, which are lifting sensations that can be a sign of an enlarged heart chamber.
So, this apical impulse we keep mentioning, what's the big deal? Well, it's simply the spot where you can best feel the heart beating against the chest wall. And if it's moved from its normal spot, that's a huge clue that the heart might be enlarged. It's a perfect example of how a simple physical finding can point towards some pretty significant pathology.
Listening to the heart is all about being systematic. First, just identify that basic lub-dub of the first and second heart sounds. Then, you're going to listen specifically over the 4 key valve areas you see here. A handy little mnemonic to remember them is all physicians take money. You just move your stethoscope in a logical path, listening for the quality of the sounds and for any extra noises like murmurs.
Okay, on to our final system, the abdomen. Now hold on, because there's a little twist here. We're going to slightly change our framework to inspection, auscultation, then percussion and palpation. Why? Well, we listen before we touch to make sure we don't stir things up and alter the bowel sounds.
The principle of having a structure, though, that stays exactly the same.
And as always, we're kicking things off with inspection. You're looking for any swelling in that upper right quadrant, but just as importantly, you're looking at the skin for those telltale signs of chronic liver disease, like spider nevi, or those prominent veins of a caput medusa.
Now, liver palpation is all about technique. You have to start low, way down in the right iliac fossa. Why is that so important? Because if the liver is massively enlarged and you start too high up, you'll miss it completely. So you start low, ask the patient to take deep breaths, and with each breath out, you move your hand up until you feel that liver edge come down and meet your fingers.
After you've felt for the edge, you can percuss to estimate the liver's total size. For the kidneys, the technique is totally different. It's a bimanual method, where you try to ballot or kind of bounce the kidney between your two hands. Now, normal kidneys are rarely palpable, but this can help you find an enlargement. And finally, a gentle tap at the back over the renal angle checks for tenderness, a classic sign of a kidney infection.
All right, we've gone through all the technical stuff. But honestly, none of it matters if you mess up the first 30 seconds. This final section is arguably the most important one for grabbing those easy marks and setting a professional tone right from the start.
Think of this slide as your pre-flight checklist. You do not skip these steps. Before you lay a single hand on the patient, wash your hands, introduce yourself, and say why you're there. Get informed consent, position the patient correctly for the exam you're about to do, and expose the area you need to see, but always maintain their dignity. These steps are completely non-negotiable.
And really, it all boils down to this one simple idea. You know, there's a saying that under pressure, you don't rise to the occasion, you fall back to the level of your training. This structure, this IPPA framework, that's your training. It's what lets you perform calmly and competently every single time without even thinking about it. So, there you have it. We've walked through the framework, we've applied it to 3 major systems. You now have the map to navigate your clinical exams with confidence. The only thing left to do is get out there and practice until this system becomes second nature. Good luck.